Our next speaker is Dr. Cynthia Owasu. She earned her medical degree from the University of Science and Technology in Ghana. She completed her residency at the Department of Medicine at Beth Israel Medical Center in Newark, New Jersey, and a fellowship in geriatric oncology at the Boston University Medical Center. She also holds a master's in epidemiology degree from Boston University. Dr. Owasu is an associate professor of medicine at Case School of Medicine, and recently appointed as the associate director for diversity, equity, and inclusion for Case Comprehensive Cancer Center. She is a renowned expert in geriatric oncology. Her current research efforts aim to increase functional status and participation of older women in clinical trials, with a particular emphasis in the breast cancer population. Today, she's going to tell us her research findings on how to reduce functional health disparities among older women, among older breast cancer survivors.
Good morning. I'd like to thank the organizers of this Innovative Research Day for giving me the opportunity to present my work. I'm truly honored and delighted to be here. My presentation is entitled Reducing Functional Health Disparities Among Older Breast Cancer Survivors, otherwise known as the IMPROVE study. And it was sponsored by the National Institute on Minority Health and Health Disparities. This was a collaborative effort between researchers at UH, Case Western Reserve, University, The Gathering Place, Metro Health, and the Cleveland Clinic. And I want to say thank you to everybody as I continue with the presentation. So to give you a little background, back in 2012, we had undertaken a longitudinal study in older women who had been newly diagnosed with breast cancer with the aim of understanding what happens to their functional health during the course of 1 year. And the reason why functional health is important is that it's a summary measure of health for everybody. And when we say functional disability, it's simply measured with activities of daily living. Can you get out of bed without help? Can you get out of the shower? Can you drive? Can you take your own medication? These are very basic. Now, we enrolled 190 women into that study. And what we found was that at baseline, African Americans were 4 times more likely than non-Hispanic whites to have functional disability at baseline. And then when we followed them forward in time for 12 months, we found that women of lower socioeconomic status were 2.5 times more likely to develop a decline in their functional health over that 12-month period. So with that preliminary data, we applied to the NIH to secure funding to intervene on the functional health, particularly the racial disparities and socioeconomic status disparities that we had just discovered. So these were the specific aims and hypotheses of the study. The first specific aim was actually a qualitative study. We needed to examine and understand the knowledge, attitude, and preferences of older breast cancer survivors towards exercise, and to use that data that we had garnered to develop and inform the intervention so that it would be acceptable and the women would be ready to enroll and there will be sustained participation. So with that information, we then went on to develop our intervention. So specific aim 2 was to determine the effect of that exercise intervention on physical performance at 20 weeks. You can see here that we've changed the outcome to physical performance, which is actually an objective measure. We wanted to do better. Functional disability is a self-report, and we did measure it, but this time we wanted to use an objective measure of functional health. Our hypothesis was that compared with breast cancer survivors in an attention control arm, breast cancer survivors in the exercise arm would be more likely to experience increases in their physical performance at 20 weeks. We had a third aim, which was to examine whether race and socioeconomic status would moderate the intervention effect on physical performance, and that comes directly from our preliminary data. And our hypothesis was that the positive effects of the exercise intervention on physical performance would be greater in African American and SES disadvantaged women, low-income women, compared to their counterparts. And that was because we had preliminary data and also from the existing literature, which showed that if you had lower performance status or lower functional health, you were actually more likely to derive a benefit from any intervention that was addressed at that poor outcome. This is the study design. After women had been screened and found to be eligible, and these women had to have stage 1 to 3 breast cancer, and they had to be 65 years and older, and they had to be within 5 years of treatment completion. If they were found to be eligible and they consented, they proceeded to do baseline assessment. They were then stratified, randomized by race, socioeconomic status, and chemotherapy. Our target accrual was 220 women. Half of these women were randomized into the exercise arm, and the other half were randomized into the support group and Fitbit arm. And by the way, this study was actually conducted and delivered at the gathering place in the community at Beechwood. After they were randomized, they went through a supervised phase of either intervention for a period of 20 weeks. At 20 weeks, they underwent an assessment to determine the effect of the intervention on outcomes. They then continued for an additional 32 weeks to complete a year of the intervention. And at the end of the year, another assessment was done. This is the patient flow chart. Our sources of recruitment. We used the State of Ohio Tumor Registry to identify most of our breast cancer patients because the study wasn't limited to UH. We were trying to recruit patients from all over. So we use that tumor registry. We also use our hospital-based tumor registry, UH and Metro Health, and then we had direct referrals, some of which came directly from the Cleveland Clinic and the Gathering Place. Altogether, we screened almost 7,500 women, of which 4,700 were eligible. We approached about 1,600 of these women, and 276 agreed to participate in the study, of which subsequently 230 actually consented. When it got time to complete the baseline, 220 showed up. And when it got time to randomization, 213 actually showed up for randomization. Of those who were randomized, 184 completed the 12-month study for a retention rate of 86.4%. Baseline characteristics of the 213 women who were enrolled. The mean age was about 72 years. 44% were African Americans. a majority had greater than high school education, majority were never smokers, majority had stage 1 breast cancer, majority completed a lumpectomy, and majority did not receive chemotherapy. If you look at the baseline characteristics by intervention arm and you look at the p-values here, you see that there was no significant difference between baseline characteristics by intervention arm, showing that randomization did work except for smoking history. And so we adjusted all models for smoking history. So here we present the exercise intervention effect on our primary outcome. So our primary outcome of physical performance was ascertained with a very well-validated instrument called the Short Physical Performance Battery. And so this is presenting those results at 20 weeks. On this axis here, you see the mean scores. Now, the blue line refers to the exercise arm, and the red line is the intervention arm. You can see 2 clear parallel arms with a p-value that is not significant. So unfortunately, there was no significant exercise intervention effect on the primary outcome of short physical performance battery at 20 weeks. That's the bad news, and that was the only bad news. We had a lot of good news. And so because what we did was, because our main aim was on functional health, we measured functional health in a variety of ways. And so here we come to the effect of the intervention on our secondary outcome, which is the 6-minute walk test. And right away, you see that there's a significant intervention effect. That then allowed us to look at race, differences in race by the 4 groups of women. And let me explain that carefully. In that cohort of 213 women, we have non-Hispanic whites in the exercise group. We have African Americans in the exercise group. We have non-Hispanic whites in the control group and African Americans in the control group. On this axis, we have the adjusted mean change in 6-minute walk test time, or distance, sorry. And if you look at these bars, you see that the group with the highest bar here is the African Americans in the exercise group. They had the largest benefit from the exercise intervention because at baseline, they had poor functional status. What we didn't expect was this group here, the African Americans in the control group. Not only didn't that support group intervention benefit them, they actually declined in their functional health. So we concluded that the exercise intervention appeared to have attenuated the decline that otherwise would have occurred in African Americans, and the African Americans benefited the most from the intervention. This is another way we measured functional health or physical function. This is the SF-36 physical function subscale. The results were very consistent with what we saw with 6-minute walk test. That allowed us to look at socioeconomic status differences. And once again, the results are very consistent. The low-income patients in the exercise group benefited the most because at baseline, they had one of the lowest scores. And similar to the racial difference we saw, the low-income patients in the control group actually declined. So we concluded from the study that combined aerobic and resistance exercise improved functional outcomes in older breast cancer survivors from diverse racial and socioeconomic status background. We also concluded that older African Americans and SES disadvantaged breast cancer survivors who do not engage in exercise during the survivorship period experience decline in physical performance and function and should be encouraged to participate in exercise. Thank you. Now take any questions.
Cynthia, very, very nice work, and thank you for a nice presentation of the work. So I love this study for many reasons. And let me comment, and then I'll ask you a question. First, not only you went across the healthcare systems, which is, about time that we do that, but you did it in the community. And as you know very well, this is something that we need to do a lot of. NIH funding now has grown exponentially for community-based studies. So I really urge everybody to think more about that. My question to you, among all the good data you have, how did you enroll 45% African Americans? Because this is the example of why it is important to have diversity among participants because of your results, right? You wouldn't have seen it. So how were you successful in enrolling 45% African Americans?
Thank you for that question. It was for a variety of reasons. The first thing was that we set out to do exactly that. In fact, we didn't reach our target. Our target was 50% African Americans. And so with that in mind, right from the word go, everything that we did was a concerted effort to achieve that. We made sure that some of our research coordinators were African Americans because we know that because of the distrust, when there's race concordance, it helps. So that certainly helped. Me being a minority and an African American also helped because I realized that when I approached a patient for consent sometimes, and the patient was African American, I realized that there was trust between myself and the patient. The other thing is that we reached out into a number of people in the community. So there's one paper that we published, which because of the time constraints, I could not bring data from that paper, that actually looked at that. And what we saw was that our direct referrals were about 80% African Americans. So reaching out into the community, talking one-on-one with researchers in the community or other healthcare professionals in the community also helped because they will then, knowing the characteristics of patients you're looking for, they will refer the appropriate patients to your study. Yes, please.
Hi, Cynthia. Great study. Quick question. So, if you look at your two arms, both had some sort of intervention because, one did have a Fitbit and support. Was there any consideration of either having a third group where it was standard care with no intervention, or would that be too hard to enroll to in the IRB and the equipoise question?
So that's a very good observation. In fact, that was one of probably the weaknesses of the study, and we realized it afterwards, hindsight 2020, because every patient had a Fitbit, and we linked the Fitbit to a database called Fitabase. So you could actually track the patients. And our patients with Fitbit were exercising because they were being motivated by the data that they were seeing from their Fitbits. And that was one of the reasons why there was no significant difference in the primary outcome, because the two groups of women were actually engaged in physical activity. And the downside or the weakness of that short physical performance battery is that it has a ceiling effect, whereas the 6-minute walk test does not. The 6-minute walk test is how far can you walk in 6 minutes. So the sky is the limit. Whereas the short physical performance battery, if you have a certain optimum health, the results end up being the same. And so, yes, a future study will certainly not have that arm in, or will have an arm that completely doesn't have any such intervention.
Thank you for the talk and the study. Wonderful. results. Do you know if there are baseline metabolic or functional metabolic or occupational hazards that dictate a poorer functional status for African Americans at baseline? Number one. Second question is, what is your hypothesis for the decline in the functional status throughout the intervention? Most of them were not receiving systemic therapy. Is that correct?
No, these were survivors. Yes. Okay. So to take that last question first, the reason why we feel that the reason why the African Americans and women of lower socioeconomic status were declining in the control group all comes back to the lack of access to exercise facilities and the ability to engage in exercise. Remember I said we had Fitbits, so we're tracking these women. The Caucasians in the control group were exercising. They had the resources, so they could exercise. However, the African American women and the low socioeconomic status women were not doing that because they just simply could not afford it. Our study from back in 2012 showed that if there was no intervention, these breast cancer patients were going to decline in their functional status. In the presence of exercise, then that decline is attenuated. So if you can afford exercise, then you're going to decline, these older women. And it really brings home or drives home to the point that we need to get to a point where exercise becomes the standard of care. And all women, regardless of race, socioeconomic status, should be able to have access to gyms. And that is where, in future, we hope that our future studies, ours and many other collaborators, we hope to be able to derive data that makes exercise the standard of care for our cancer survivors.
Thank you, Cynthia.
Thank you.